Okay, hi guys, my name's Sasank. So I'm going to be talking about diagnosing neurocomplex tachycardia. So there are some generalizations that you can make here for the acute management. So it is pretty easy to know what to do if you do find a neurocomplex tachycardia. But diagnosing it is important for long-term management and consulting cardiology. So let me just talk about the generalizations first. First of all, if the patient is unstable, you go straight to synchronized cardioversion. If they're stable with narrow-complex tachycardia, you can try vagal maneuvers first, such as blowing on an empty syringe, dunking the patient's head in ice water, Valsalva, otherwise known as bearing down like you're about to use the restroom. And if that doesn't work, you go on to use adenosine. So adenosine, 6 milligrams, rapid IV push, followed by normal saline push plus an arm raise. If they're still in tachycardia, then you can try again with 12 milligrams. Or if you're delivering via central line, use half the dose that I've stated. So another thing to remember is that patients' status post heart transplant, adenosine is actually contraindicated. So the next step, if vagal maneuvers and adenosine doesn't work, is you do acute treatment using pharmacologic cardioversion, using beta blockers, calcium channel blockers such as diltiazem or amiodarone. Remember, for diltiazem, you cannot use if they have a history of heart failure with reduced ejection fraction. And for amiodarone and all of these other pharmacologic cardioversions, and they have a rhythm of atrial flutter or atrial fibrillation, and it's more than 48 hours, make sure you rule out the intraatrial clot using a transthoracic echocardiogram. And so let us now talk about diagnosing the neurocomplex tachycardias. So this is not important for the acute management but for consulting cardiology, it's important to make the recommendations. So I'll talk about each of the diagnoses, what is caused by, and the pathology, and an easy way to remember all of them. For the neurocomplex tachycardias, the first one I'm going to talk about is sinus tachycardia. So in this, the rate is greater than 100 with a maximum heart rate of 220 minus the H. So if it's outside of that bound of that heart rate, then it's a different diagnosis. So this has a general gradual onset and can be due to causes such as hypovolemia, hemorrhage, withdrawal of substance such as ethanol, benzodiazepines, opiates, beta blockers, intoxication, fever and infection, pain, hypoxemia, pulmonary embolism, anemia, tamponade, dissection, and other endocrine problems, including hyperthyroidism, adrenal insufficiency, and pheochromocytoma. So it's important to reverse these causes if possible. You can refer to the ACLS cardiac arrest video for more detail. So the easy way to identify if it's narrow complex tachycardia and there's a regular rate and the P waves are normal, then it's likely sinus tachycardia. Then we have a focal atrial tachycardia, or simply called atrial tachycardia, due to a abnormal automaticity at a single atrial focus other than the SA node, or it's due to a re-entrant circuit within the atria. So there are discrete P waves, but they have abnormal morphology and axis. So for example, the P waves will be inverted in the inferior leads 2, 3, and AVF. So the classic cause is digoxin toxicity, and you can also have this in normal hearts. So a simple way to identify this is if it's regular narrow complex tachycardia and there's abnormal P wave morphology, it's likely atrial tachycardia. Next thing I'll talk about is junctional tachycardia. So this is due to increased automaticity within the AV node, and the P waves will be absent or buried within the QRS. It can also be inverted or retrograde. And so this is very similar to AV-NRT and AVRT. So AV-NRT is atrioventricular nodal reentrant tachycardia. So this will have a rate of 150 to 250. And so for this one, the P waves are retrograde if they're visible. The P waves don't have to be visible in this rhythm. And atrioventricular nodal reentrant tachycardia can trigger PAC and PVC and this happens in young adults. And so then we have orthodromic atrioventricular reentrant tachycardia, otherwise known as AVRT. So this is due to ventricular depolarization that occurs outside the AV node, and an accessory pathway can lead to retrograde conduction. So differentiating between these three, junctional tachycardia, AV-NRT, and AVRT, is difficult. But if you notice that there's a retrograde P wave, it's likely one of those three. And then we have atrial flutter with regular rhythm. So for that one, there will be clear flutter waves and the rhythm will be regular narrow complex tachycardia. And yeah, so let us now talk about irregular narrow complex tachycardias. So the differentiating factor is that the RR intervals are variable in length throughout the EKG. Remember, to calculate the rate in an irregular rhythm, you will have to count the number of QRS in lead 2 and multiply by 6. The first one I'm going to talk about is multifocal atrial tachycardia. So this will have a rate of 100 to 150, and there will be discrete P waves, but of greater than or equal to 3 morphologies. The rhythm is irregular due to varying PP, PR, and RR intervals. The conditions this is seen is in COPD, pulmonary hypertension, coronary arterial disease, electrolyte disarray, and immunophilin and theophylline use. So in this one, there's basically multifocal foci. So there's multiple points in the atria or other places other than the SA node that is causing the atrial depolarization. So a simple way to remember this is if it is irregular narrow complex tachycardia and there's greater than or equal to 3 P wave morphologies, it's likely multifocal atrial tachycardia. Next, I'm going to talk about atrial fibrillation. So atrial fibrillation is there's going to be no P waves and there will be fibrillatory waves present and variable RR intervals. So there is abnormal atrial rhythms that lead to reentrant pathways or ectopic rhythms, either from pulmonary veins or other places in the atria. And this will lead to a ventricular depolarization. So if there's a pre-excitation depolarization, there's a irregular wide complex tachycardia. So remember, a general rule of thumb is if it's narrow QRS, then the rhythm is supraventricular. That is the pacemaker. If it is wide complex tachycardia, then the foci is usually ventricular. And I misspoke. So if the atrial fibrillation is associated with pre-excitation, the result is an irregular wide complex tachycardia. So next we're going to talk about atrial flutter with variable block. This will also result in an irregular narrow complex tachycardia. So if this is isthmus dependent, this is due to the classic reentrant pattern. So what happens is during the depolarization, the pattern takes a long time to depolarize the entire atria, and by the time the earliest depolarized atrial myocardium is recovered, it will start the reentrant pathway. And there's also non-isthmus atrial flutter, in which the circuit uses other areas such as after surgery ablation or atrial scarring. Another thing to identify atrial flutter is if it's counterclockwise or clockwise. So if it's counterclockwise, there's negative flutter waves in the inferior leads. If it's clockwise, then there's positive flutter waves in the same leads. And in this one, the atrial rate is usually between 250 and 300. So that is narrow complex tachycardia.